Okay, let's move to our first presentation. That's a review of the diseases of the upper GI tract. I don't have anything to disclose today or any other day that will in any way create any bias in the information I'm about to present. Here's what we're going to look at. Dyspepsia, disorders of the esophagus, one of them being motility, the other being GERD. And then, of course, we got to know about peptic ulcer disease and the issue of H. pylori, which accounts for most ulcer disease. So if we look at esophageal disorders, we've either got a motility issue, a reflux issue, an inflammatory issue, or a tumor. Those are the only four things. When we look at signs and symptoms, dysphagia, odynophagia, perhaps chest pain, and regurgitation. Those are the three big symptoms we want to get from the history. Now, when we look at motility disorders from the standpoint of the boards, I want you to be aware of three things: achalasia, spasm, and scleroderma. And let's start with this question based on those issues. Which of the following is an indicated treatment for achalasia? Are we going to use beta blockers, alpha blockers, calcium channel blockers, or H2 blockers? So we're treating this. What are we going to use? Okay, and what did we choose here? Yeah, calcium channel blockers. I need something that's going to relax smooth muscle. I'm going to need something that relaxes smooth muscle. So here's what you need to know. Achalasia, we have the absence of peristaltic progression. The symptom here, clinically, they'll have dysphagia with solids and liquids. These individuals are at an increased risk of squamous cell carcinoma. We diagnose all of these disorders the same way, either a barium swallow or manometry. Most of the treatment is the same. Long-acting nitrates, calcium channel blockers. Sometimes those with achalasia are going to need a pneumatic dilatation. When we have esophageal spasm, these are spastic motor disorders. These patients will present a lot with heartburn and chest pain, and I'm thinking, could this be coronary artery disease? Barium swallow, again, the same treatment. Scleroderma. Now, scleroderma, thank goodness, is not very common. However, 90% of patients who have this disorder will eventually have esophageal involvement. The symptoms, there is a huge continuum. We manage this by managing the reflux. We treat esophagitis. They may need a prokinetic agent. Okay, that's what you need to know about motility disorders. GERD, common. It's the most common GI-related diagnosis in the US, and upwards of about 15% of the population have frequent GERD symptoms. Now, most of this you don't even hear about because they're just using over-the-counter medications to treat this occasionally. The typical symptoms, heartburn, acid regurgitation. The atypical symptoms, wheezing, hoarseness, of course, atypical chest pain. The diagnosis of GERD, very important here. History and physical, and if you don't have warning signs and symptoms, which we'll look at in just a moment, it's a trial of empiric therapy. Here's the question. Which of the following diagnostic tests is recommended in the patient with GERD who's refractory to that maximum PPI therapy? So they've got the right history in a physical examination, typically an absence of any epigastric tenderness. You put them on a PPI for 8 weeks, and they still have symptoms. What are we going to do next? Esophageal manometry, 24-hour pH monitoring, barium radiology, or a urea breath test. Which of those are we going to do? Okay, we have a learning opportunity, and the correct answer is B. Okay, I'm going to point out here, if you have GERD, if that's the diagnosis you're working with, the recommendation is to not test for H. pylori. Not. Europe, they do. US, we do not. The recommendation is not to do that. So any question on the exam where you are convinced that the diagnosis is GERD, please do not be looking for H. pylori. Now, in terms of the diagnosis here, remember there's no gold standard. We're giving an empiric trial of therapy. Some of you are thinking, well, I would have done an EGD. That is to assess for complications. Now, what are the complications we're thinking of? Erosive esophagitis, stricture, Barrett's, cancer. But when you look at, can I determine pathologic reflux? The EGD actually lacks adequate sensitivity. So here's the diagnostic testing. No manometry, It's only recommended if you're going to do a preoperative evaluation, like if they've got to go for a Nissen. The 24-hour pH monitoring, that's what's recommended. Now, some of you would question, well, how is that going to change the management? It's not going to necessarily change the management, but it's going to confirm the diagnosis. It's not recommended in routine diagnosis, and it is not required in patients who have Barrett's. Now, keep in mind, we're going to talk about it in a second. Barrett's is uncommon. We think about it, it's easily put on an exam, but it's uncommon. Barium radiology, not recommended. There would be limited usefulness here. Screening for H. pylori, as I said, no. Eradication is not routinely required as part of anti-reflux therapy. There's really insufficient evidence available in the United States. It is a bit controversial because in Europe they do recommend screening, but any question on the exam, we're not doing that for GERD. We put them on the empiric trial. Now, what would be those alarm symptoms where I'm like, okay, I cannot just put them on an empiric trial. We got to worry about some other issues. Well, doc, I've got GERD and my stools are bloody. Or I've got a chronic cough. There's early satiety. There's hoarseness. There's pain on swallowing. And I'm down, 30 pounds and I'm not trying to lose weight. Okay, those are all alarm symptoms. We got to be thinking beyond typical GERD here. In those patients, you want to get an upper endoscopy. They're at high risk for complications. So I want to go looking already for a complication. Here's the diagnostic testing summary. I would print this out and put it with your study materials for review. Now, the treatment. PPIs are the most effective. They relieve the heartburn. They're better than H2 blockers. They're better than prokinetic agents. I know you're thinking, well, people say this one works better for me, etc. The different PPIs have similar efficacy at standard doses. Why one works better for another, you can ask the same question of NSAIDs. You can ask the same question of facial tissues. Why do some people like puffs versus Scots, et cetera, et cetera? Long-term use may increase the fracture risk, but there's inconsistent evidence when we particularly look at the big kahuna, which is hip fracture, okay? And that's always the one we're worried about in aging individuals because as we talked about with geriatrics, remember there's a rule of thirds with hip fractures, particularly in aging individuals. A third of them will be dead in a year from that hip fracture. Not from the fracture itself, but because of complications. So as we think about the treatment, let's take a look at this question. In discussing the initiation of a patient on a PPI, which of the following is a potential risk of therapy that I need to review with the patient? There's a decreased risk of CAP. There's a decreased risk of C. diff. There's an increased risk of vitamin B12 deficiency, or there's an increased risk of iron deficiency anemia. So which of those do I want to include in my conversation? Because if I don't, they're going to read the package insert and they're going to believe their pharmacist, which they should, to say, I'm not